My Lady, I, alongside Mr Weaver, Mr Mark Bradley and Mr Wilcox of Hudgell Solicitors, represent three groups who together are recognised by the inquiry as the COVID vaccine adverse bereaved and reaction groups. These three groups are the UK CV family, the Vaccine Injured and Bereaved UK, and the Scottish Vaccine Injury Group. You will hear powerful evidence from Kate Scott, Charlotte Crichton and Ruth O'Rafferty on behalf of these three groups during your inquiry. The thousands of people that these three groups present what is an uncomfortable truth for many, that vaccine injury and death are part of the pandemic story. These are men, women and children who are otherwise healthy, who followed public health advice and voluntarily attended to receive their vaccine. They include doctors, healthcare professionals, carers and parents who accepted the vaccine thinking not only of themselves but of their patients and those who they cared for. Those I represent are neither anti-science nor are they anti-vaccine. They are real people with real experiences. And my lady, this inquiry must recognise and acknowledge the real experiences of the vaccine injured and bereaved and their need for real treatment, real care and the need for real change in the way that vaccine injuries are reported and addressed. For too long, they've been ignored by the government, public health bodies and the media. The COVID vaccine adverse reaction and bereaved are not just an unfortunate statistic or collateral damage to the government's vaccination strategy. They are individuals and families calling upon the health service and the government for urgent help. So, my lady, what does the inquiry need to understand about COVID vaccine adverse reactions and bereavement in this module? First, the inquiry must understand the decisions that were made around the production, regulation and rollout of the COVID-19 vaccines. The groups I represent question what was a so-called acceptable risk of the COVID-19 vaccines to them. And were those risks communicated in an effective way, which meant that members of the public were able to provide informed consent to vaccination? There was clearly a political drive for the UK to be seen at the forefront of global vaccine development, and we asked the inquiry to interrogate whether political pressure created an environment in which the assessment and the regulation of the safety of vaccines was not as robust as it should have or could have been, or whether a focus on vaccination meant the alternatives, such as therapeutics, were overlooked. We understand, for example, that the inquiry will hear evidence that the UK government agreed to pay AstraZeneca in advance for the supply of a potential vaccine, and that the government also agreed to indemnify them and the other pharmaceutical companies, such as Moderna and Pfizer, in respect of any losses from certain third-party claims. The purpose and the impact of this indemnification needs to be fully understood. Was this standard practice? Or was this a recognition by the government and the pharmaceutical companies that there was a safety risk in the development and distribution at such speed, which required special indemnification? The COVID vaccine adverse reaction and bereaved groups also want to understand the data available to the companies from their clinical randomised trial data and how this information was presented to the UK regulators. Where vaccines were scaled up from those tested in clinical trials, were the regulators presented with accurate safety data for the products that were in fact rolled out to the public? We also ask how did the MRHA and the JCVI scrutinise data, particularly with regards to those who commenced but did not complete the trials? Second, my lady, the inquiry must understand the post-rollout surveillance and monitoring of the vaccines. Although the desire for a vaccine at speed may have been understandable, the fast-track process for the development and rollout that followed meant that the stringent post-authorisation surveillance and monitoring was essential, as was public education and information on how to identify and report any adverse reactions to the vaccine. Essentially, the vaccine rollout put everyone in the UK in a Phase 4 post-authorisation trial. We were the real-world data that Mr Keith Casey referred to this morning. This made it imperative for the government and the NHS to ensure that there was an effective system in place that was well organised and signal sensitive to monitor, detect and treat any adverse effects. My lady, adverse reactions were to be entirely expected. As acknowledged by Mr Keith, King's Counsel this morning, any statistical probability on a population level of serious side effects such as thrombosis, thrombocytopenia, myocarditis, Guillain-Barré syndrome and other serious haematological, neurological, immunological and musculoskeletal injuries does not undermine their severity when they occur to individuals. Therefore, it must have been clear when rolling out the vaccine to millions of people, if the planning assumption was that 75% of the population were to be vaccinated, that there were likely to be vaccine-related deaths and serious vaccine injuries, however rare on a population level, that would require urgent identification, treatment and care. Many of us were vaccinated by our GP or our local healthcare provider. The BMA estimates that in England this was by over 70% of those vaccinated. We ask, were GPs also provided with sufficient information and training in relation to how to spot and report vaccine injuries? Many of us were vaccinated in mass vaccination centres and received multiple doses across different settings and from different manufacturers. We ask, were those who were vaccinated and vaccinating always advised of the latest information surrounding known risks? Was the patient information leaflet always up to date and available to those being vaccinated? Where changes were made to a safety profile, the inquiry must question whether public health messaging was early enough or clear enough in order that individuals could properly assess the risks to them. Also, was there a full understanding of whether multiple doses would impact of any risk of injury or further compound any existing vaccine injury? As Professor Stephen Evans points out in his written report to the inquiry, it could be said that safety is always provisional, in the sense that with rare events it may take some time to be detected. The logic to this statement is that vaccine risk assessment and risk management must retain an open mind to the occurrence of adverse events. What Professor Evans calls the degree of an individual or a system's index of suspicion.